Good afternoon, everyone. Thank you for being here, and thank you to SEGM and the organizers for inviting me to talk to you all. It's an honor to be here. Okay, so right, you've got the title of my talk there. I'm going to be talking about autonomy. There'll be some overlap with the previous speaker, but we're going to get into some further depth about autonomy, which has been playing an increasingly central role in discussions of pediatric gender medicine. So this is a roadmap for my talk. I'm going to start off by talking about principlism, and then focus on one of the biomedical ethical principles of autonomy. That will lead to a discussion of paternalism and medical paternalism, then informed consent. And then after having some of that sort of theoretical background available, I'll start talking about pediatric medical transition within that context. Okay. So principlism is a bioethical framework that is very commonly adopted by clinicians and health systems. You can read about principlism. It's expressed in the Belmont report, which was published in 1978. By what was then the National Health Service in the United States, largely in response to the infamous Tuskegee syphilis study. And then you have, next to that is the Beauchamp and Childress textbook that really sets out principlism in a systematic way. This is something sort of known as like the Bible of bioethics. It's an extremely influential book that has shaped thinking in bioethics. All right, so what is principlism? As I just said, it's an influential ethical framework to help guide clinicians and researchers, and it includes four principles. The first principle is non-maleficence, and the basic idea there, do no harm. Doctors are not supposed to harm their patients. That shouldn't be too controversial. The second principle is beneficence. They should also promote their welfare. Well, what's the difference between those two? You could have two interventions, neither of which are harmful, but one of which is much more beneficial. Well, they should choose the one that's more beneficial, right? So there's a difference between non-maleficence and beneficence. Third is the principle of respect for autonomy, and that's what I'm going to be focused on most today. And this means that clinicians should be abstaining from controlling influence when it comes to their patients, or at least their mature, competent patients. And finally, I won't say anything about the principle of justice, but justice requires that benefits and harms are fairly distributed across a population, sort of a population-based principle. Okay, so let's talk about autonomy, and that'll get us to the principle of respect for autonomy. What is autonomy? So intuitively, when we say that somebody's autonomous, we have things in mind like, well, they're leading their own life. They're not being pulled by others or pushed by others. Somebody who's autonomous is their own person. These are just sort of common everyday ways of expressing autonomy or describing autonomy. Now, a little more detail. So this is from the Belmont report. Their definition of an autonomous person is an individual capable of deliberation about personal goals and of acting under the direction of such deliberation. So you have to be able to set goals for yourself. You have to deliberate about those goals. Right, and act on the basis of your deliberation. Beauchamp and Childress get into a little more detail. They understand autonomous action in terms of normal choosers who act intentionally, with understanding, and without controlling influences that determine their action. As we'll see later, there's going to be a lot of overlap with the informed consent process. Informed consent is a mechanism responding to people's autonomy. Okay, so here's one more statement of autonomous action from a relatively recent paper by two philosophers and bioethicists, both leading figures. Millam at the time was at NIH. He's now moved on to a university. In any case, roughly speak, this is how when analytic philosophers are speaking roughly, this is how they speak. All right, so an agent A performs an action X autonomously if and only if A performs X intentionally, with sufficient understanding, sufficiently free of controlling influences, and A decided or could have decided whether to do that thing, whether to X, in light of A's values. So you can see that there's a certain amount of cognitive sophistication required for being autonomous. And this is going to be important when we start talking about children minors, and why we allow paternalistic action in the case of children, but maybe not in fully mature adults. Okay? So you have to have performed that action intentionally. You have to have had sufficient understanding. You have to have not been coerced or forced or manipulated. And you have to have done it in light of your values. Sorry. So these are relatively high-level cognitive capacities. I'm not going to go through this whole thing, but philosophers distinguish between what is it to do an action autonomously, what is it to have a desire that's autonomous, right? So a desire is a kind of attitude. Some desires that we have, we think are autonomous and some aren't. So all of us have desires that we might experience as alien, desires that we don't endorse. So the classic cases here is like, the addict who might have a desire for the drug, but feel that desire is somehow alien to them. They don't endorse that desire, right? So you can start to think of yourself and, what desires do you have that you really fully endorse and have you reflected on? So philosophers talk about autonomous desires in addition to autonomous action. And of course, there's a relationship because oftentimes we act on the basis of desire. So we can ask, well, was the desire autonomous? And then we can ask, was the action on the basis of that desire autonomous as well, too? All right, so this just gives you a flavor of how philosophers think about autonomy. All right, so there's a distinction between autonomy and respect for autonomy. Remember, respect for autonomy is one of the bioethical principles. So autonomy itself is the capacity that many human beings have to varying degrees, right? And one can be more or less autonomous with respect to one's choosing, one's acting, believing, desiring, and so on. So autonomy is a kind of capacity or ability that we have, which was I just showed you a few analyses on the previous slide. It's generally agreed that autonomy is good. It's a good thing for people to be autonomous. We encourage autonomy. Parents want their children to be autonomous. It's thought to be instrumentally good because people tend to be good at figuring out what their own interests are. And so if you can be autonomous with respect to your desires and your actions, you're more likely to achieve the things that you really want to achieve. Your life is going to tend to go better. And some people think that being autonomous is also intrinsically good. There's just something good about being an independent person who's not controlled by external force or internal alien desires and so on. So the principle of respect for autonomy expresses a moral requirement grounded in that capacity, right? So autonomous agents have certain kinds of rights in virtue of their autonomy. So respect for autonomy is a requirement grounded in that ability, but they're two different things, okay? So if you're autonomous, you have certain autonomy rights. What are autonomy rights? Well, if a person is autonomous with respect to some domain, so for example, what they can do with their own body, what they can say, for whom they wish to vote, then that person has a right against interference from others in that domain, so long as other important rights are not violated. So I have autonomy rights over what I do with my body, but I can't punch you in the nose, right? My right to move my body wherever I want, my autonomy right, ends at your body because you have rights to bodily integrity, okay? So our autonomy rights are not unlimited. They end where other serious rights begin. Importantly, and this is something that our previous speaker discussed, autonomy rights are generally understood to be negative rights. So philosophers distinguish between negative rights and positive rights. A negative right that you have is a right against interference. So my right to life means other people just shouldn't kill me. Just don't interfere with my being alive. Property rights are negative rights. You can't mess with my stuff without my permission. A positive right, on the other hand, is a right that other people provide you with something. So if you think that there's a right to health care, but then if I have a right to health care, then somebody out there, the government say, has a duty to actually give me something. And this is a really important distinction because as we'll see later, the autonomy-based arguments in the pediatric gender medicine space seem to construe autonomy as some kind of a positive right, that physicians provide something rather than that physicians simply not interfere against someone's will. Okay, that negative and positive distinction is important. Now, as I said earlier, autonomy is not unlimited. People's autonomy rights are not unlimited. And there's a really interesting literature in political philosophy and social philosophy on when you can interfere with someone's liberty, when you can interfere with someone's autonomy, rather. These are just some different views. These apply to this relationship between states, typically, and the people within their jurisdiction. So some people think that you can override autonomy when someone does something that's morally wrong. So think about anti-sodomy laws. Okay? These barred consenting adults from engaging in certain kinds of sexual practices because whoever wrote the law just thought it was wrong. Even if it's not harmful, even if it doesn't interfere with anybody's rights, it's just wrong, and we should legislate against it and limit people. Now, these are legal moralism is not a very widely endorsed principle in liberal societies. Nobody really endorses legal moralism. Second is the offense principle. This says that if you do something or say something that's offensive, we can stop you. The state can come in and put you in jail or fine you or whatever. Some great work by Joel Feinberg on the offense principle. These are partially endorsed in liberal societies. So think about debates about pornography. Some people think pornography should be banned because it's offensive. That's not the only reason you might think it should be banned, but it's offensive. Liberal societies tend to permit pornography, but there are limits. You can't put pornographic billboards up on the main highway, at least not in the United States. So there are some limits where it looks like the offense principle is invoked to constrain people's autonomy. The harm principle is really widely endorsed. John Stuart Mill, the famous 19th century utilitarian philosopher, argued that the only basis on which a state could restrict our liberty was to avoid harm to others. Okay, so this is just widely endorsed. Every liberal society is willing to constrain us and limit our autonomy when doing so is required to protect other people, okay, and harm to others. Paternalism, and that's what I'm going to focus on. Paternalism, the paternalistic views hold that it is permissible for the state to interfere with our autonomy when doing so is good for us. And this is very much relevant in medicine, because medicine is quite paternalistic, as we'll see. And so the question is, how do we balance, in some cases, people's autonomy rights against the medical profession's obligations to protect and promote health? Okay, so there's there's many different kinds of paternalism, but the two big distinction that philosophers often draw is between hard paternalism and soft paternalism. So roughly, to treat someone paternalistically is to exert controlling influence, for example, force or coercion over them for their own good. So force is when you're physically forcing someone to do something for their own good, shoving a pill down their throat, strapping them down to the table in a hospital or something like that, right? Coercion generally takes the form of threats, right? If you don't do what I want you to do, I will make you worse off than you would otherwise be. All right, so what's the difference between soft and hard paternalism? Soft paternalism is directed against someone who is non-autonomous with respect to the action the paternalist seeks to limit or control. And this can be pretty easy to justify, okay? Because if an individual is non-autonomous in some domain, then you're not going to be violating their autonomy rights when you coerce them to do something for their own good. So when doctors give an injection, give a vaccine to an unwilling child, they're being paternalistic. That's soft paternalism because the child is not autonomous. Forcing an adult to receive an injection, say, could be a case of hard paternalism if that adult is fully autonomous. Hard paternalism is the kind of case I just mentioned, right? This is when you're forcing someone to do something for their own good and they're fully autonomous. And this is generally, as we'll see, very much frowned upon in medicine. We just don't allow it. But hold that distinction between soft and hard determinism in mind as we proceed. You can just find statements like this all over the place. The famous court case from 1914, and the words of Benjamin Cardozo, one of the judges, "Every human being of adult years and sound mind has a right to determine what shall be done with his own body. And a surgeon who performs an operation without his patient's consent commits an assault for which he's liable in damages." The details of this case, I don't remember all the details, but a woman had gone to the doctor. She was experiencing abdominal pain. They found some kind of a lesion, I believe. They wanted to operate, and she allowed them to go in order to diagnose, but she did not give consent for them to remove the lesion. And they did remove it, and she sued. And this is the statement that you get from a judge, which was really influential because it showed doctors, now the courts are going to be watching what we're doing and we have to start taking people's autonomy more seriously. From the same paper I cited before, the DeGrazia and Millam chapter, crucially for bioethics, an autonomous person has the right to decide whether other people may do things to his body. He can exercise this right by refusing a medical treatment that his doctor thinks would benefit him. So these are just every bioethics paper you read where people talk about respect for autonomy, it's always the same kind of idea, which is that patients who are competent have a right to say no. And you see it in the various legal cases that were really influential. It's a right to say, you may not do that to my body without my consent. It's that negative right. Keep emphasizing that because it's sort of like a truism in bioethics, and yet it's become forgotten. Okay. It's very widely accepted that it is morally impermissible for clinicians to intervene on a patient's body without obtaining the patient's informed consent. Morally authoritative consent has two conditions. It has to be sufficiently informed, so doctors have to tell you what the risks and benefits are of the intervention. They can't lie to you. They have to tell you all sorts of things about the interventions that might impact your decision. And your decision, your consent has to be sufficiently voluntary. So you can't be acting under duress, under force, under coercion. Some people think there are coercive offers. I'm not going to talk about that. But you have to be consenting voluntarily in an informed manner. So notice, this is important. These two central components of informed consent just mirror what it is to be autonomous, right? So procuring informed consent is the mechanism by which clinicians respect patient autonomy. This is required for autonomous patients only. It doesn't apply to non-autonomous patients. Soft paternalism is relatively common in medicine. Recall what soft paternalism is. It's when you force someone to do something for their own good, even against their will, when they're not autonomous. Fairly common. It happens when clinicians override the preference or choices of patients who are relevantly non-autonomous for the patient's own good. And again, no, you don't have to worry about this vis-a-vis autonomy rights because they're not autonomous, so they don't have those rights. Hard paternalism, on the other hand, is generally considered impermissible in medicine because it does violate patients' autonomy rights. But there are some exceptions. So you can think about what in the United States, what the Food and Drug Administration does. You can't just sell certain chemicals at Walgreens, drugstores on the corner. Things have to be licensed. Medical licenses are issued very carefully. You have to have a medical degree and so on. That is a form of paternalism too. You can't just go to the store and buy opioids. So there is some hard paternalism in medicine, but in the clinic, in the office, it doesn't happen, or it shouldn't happen. Okay, so that's a bit of kind of background about autonomy. I'll turn now to pediatric medical transition. Everybody here, or just about everybody here, is familiar with the basic picture. Those words are too small for me to read, but the first step is generally going to be a social transition, adopting chosen names, changing pronouns, using certain spaces, and so on. And then medical transition can begin with puberty blockers as early as Tanner stage 2. The next step is cross-sex hormones, and then surgery is generally the final or the last step. All right, so now I'm going to talk about two competing rationales that we're seeing in terms of how people understand how to justify these interventions. Okay, the traditional rationale is that medical transition protects or promotes patient health. This is the rationale that you see expressed in the early Dutch studies. Okay, so if we bring the child's body into conformity with what is typical of members of the sex with which they identify, the child's distress or impairment or suffering will be alleviated, and these benefits will extend into adulthood. That was what this whole thing was about. Right? If we intervene earlier, the individual will grow up to pass better, and that's going to lead to reductions in gender dysphoria, depression, anxiety, and what have you. That's just the standard medical rationale. And this rationale is reflected in the research. The vast majority of the research that we've seen in this field, certainly since the 2011 DeVries et al. Study, it focuses on these sorts of outcomes, right? You give an intervention and you look at the effects on health-related outcomes. So gender dysphoria, depression, anxiety, suicidality, and so on. Okay? That's what the research is about, and that reflects this traditional rationale that you're trying to protect and promote health. So here are just some statements, again, endorsing or just expressing the traditional rationale. So the first is from the former U.S. Assistant Secretary of Health at Health and Human Services, Rachel Levine. Gender-affirming care is medical care. It is mental health care. It is suicide prevention care. It improves quality of life, and it saves lives. It's based on decades of study. It's well-established medical practice. Next is a statement from the AMA, the largest medical association in the United States. Gender-affirming care is medically necessary, evidence-based care, improves the physical and mental health of transgender and gender-diverse people. And finally, we have a statement from WPATH. Studies consistently show its positive impact, including improved mental health, overall quality. So forget for a moment whether those statements are true or false. The rationale is clear enough. These things are good for people's health. Okay? That's the rationale. Now we have a separate competing rationale that I think was always, really, and if you look at the history, it was always there, but now we're seeing it expressed more prominently and explicitly. So here's a statement of that rationale from Florence Ashley, a legal scholar in Alberta. Adolescent medical transition aims at preventing or altering the development of sexual characteristics to achieve the individual's gender embodiment goals. That's what it aims at doing, okay? The effectiveness is defined by its ability to achieve the sought physiological outcomes, a standard indisputably met. So if you want breasts, you take estrogen, you get breasts, done. That's what the drugs are for, on Ashley's view. Offering transition-related medical care to adolescents is ethically justified, regardless of proven health benefits. That is, regardless of whether it is proven that adolescent medical transition causes an improvement in mental health. So now you see this rejection of the kind of rationale that we just saw in the previous slides. It doesn't matter whether it improves mental health. All it needs to do is achieve the individual's gender embodiment goal. So now we're already doing something different. We're appealing to a different kind of justification. We can move even further. So that's Andrea Long Chu, I think has a Pulitzer Prize, but an author and a trans woman. 2018 is in the New York Times op-ed, I believe. I was not suicidal before hormones. Now I often am. I tell you this not because I'm cruising for sympathy, but to prepare you for what I am telling you now. I still want this, all of it. I want the tears. I want the pain. Transition doesn't have to make me happy for me to want it. Left to their own devices, people will rarely pursue what makes them feel good in the long term. Desire and happiness are independent agents. It's not even about happiness. I just want it, period. That's the justification, okay? And then from a more recent long piece in, I think, New York Magazine, this was focused mainly on children. We must be prepared to defend the idea that, in principle, everyone should have access to sex-changing medical care, regardless of age, gender identity, social environment, or psychiatric history. Just pure desire-based justification. Okay, so you might think, well, Florence Ashley, Andrea Long Chu, sort of activist types, people, it's fun to talk about this stuff in the seminar. People can make radical claims, big deal, okay? But actually, you start to see this, this sort of approach reflected among people who you might think should be, who are serious people. So this is a recent paper, I think one of the most remarkable papers I've seen in this field, remarkable for several reasons, is the Oosthoek et al. Paper with Anne-Lou de Vries as an author on this. Anne-Lou de Vries, of course, was lead author on the 2011 and 2014 foundational Dutch studies. So what do they say in this paper? The teleological narrative commonly portrayed in medical literature, which we aim to challenge. We're going to challenge, right, this narrative, a progression from doing bad to doing better, ultimately leading to an improvement in the individual's functioning. They want to challenge this idea that the point of the interventions is to lead to an overall improvement. Sorry, I shouldn't laugh. Overall improvement in the individual's functioning and well-being. It's sort of a very radical claim, especially by these are people who work with these patients and are senior clinicians and researchers. Another statement, while these interventions often aids in achieving gender congruence and overall improvement, the justification of this care practice should not be conditional on this logic of improvement. Okay? So you don't have to show benefit to health. All right, where else do we see this distinction between a traditional approach and this new novel approach? You see it, I think, in the diagnostic manuals. So I feel a little awkward talking about the DSM-5 with people in the room who helped write it, but they'll tell me if I'm wrong. So the DSM-5 reflects the traditional rationale. You have two conditions, basically. You have the condition of incongruence, and that's defined according to certain criteria. But you have this second condition, condition B, which is quite important, right, where the condition is associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. So you see there a kind of clinical rationale that's traditional. These patients are suffering, they've got distress or impairment, this is a problem, let's try to fix it. All right, so how does Principlism framework apply to the traditional rationale? Well, as many of us already know, and as we've heard at this conference, some critics or skeptics of pediatric medical transition point to problems with the underlying clinical evidence, for example, by reference to systematic reviews. So does it reduce distress? Do these interventions reduce impairment? Not clear that they do, right? There's reasons to believe they don't. So the principles of non-maleficence and beneficence are violated if these interventions are not effective, given the risks of harm. So you need a positive risk-benefit ratio, and if you don't have one, then you're violating the principles of beneficence and non-maleficence. What about the ICD-11? This reflects the gender embodiment goals approach. So I'm just going to read the first part of the diagnosis, but this is the diagnosis for adolescence and adulthood. So it includes anybody who's, I guess, beginning puberty or in adolescence. So you're lumped in with the adults, even if you're 12 or what have you. But this condition is characterized by a marked and persistent incongruence between an individual's experienced gender and the assigned sex, which often leads to a desire to transition in order to live and be accepted as a person of the experienced gender. Okay. So what are the criteria for the ICD-11? So this is from a paper from last year by Jack Drescher and Yarbrough. You have to meet at least two of the following four conditions. The first thing to note, if you look at them, there's no distress condition, there's no impairment condition. You have to have two of the four. So the first is a strong dislike or strong dislike or disagreement with primary or secondary sexual characteristics due to an incongruence with the experienced gender. A strong desire to get rid of some of those sexual characteristics, again, due to the incongruence with the experienced gender. And then 3 and 4, rather than being about negative attitudes towards your own sex characteristics or positive attitudes towards the sex characteristics that you want. Now, I have in red a bit of the first two conditions because you can see there's a problem here. Remember what's on offer here, criteria for meeting the definition of gender incongruence. And what conditions 1 and 2 do is they build a gender incongruence into the criteria. So this looks like a problematic circularity, right? So you have to have a dislike with your primary or secondary sex characteristics, and this dislike has to be due to the incongruence. But we're supposed to be giving criteria for incongruence, so this is kind of odd. But put that to the side. You see here that what you've got are just preferences for the kind of body that you want, essentially. All right, so how does Principlism, how does that framework apply to this rationale, the gender embodiment goals rationale? The principles of beneficence and non-maleficence, construed in terms of health-related welfare or interests, may be violated. And there's not even an attempt here to say that what we're after is improving health. So if you if you set back the health-related interests of a person, that's no problem for this view, right? Because improvements in health are no part of it, no part of the diagnosis. What about respect for autonomy? This is the argument that people advance. People have autonomy, and they should be able to change their bodies however they want. But now recall, I'm just going to go back to what I said earlier about the nature of autonomy rights. Respect for autonomy is here construed not as an autonomous patient's right to refuse offered interventions, but rather as a positive right. That is, a right which imposes a duty on clinicians to offer some interventions just to satisfy the patient's current desires. So here autonomy is being construed as a positive right. And nobody thinks that autonomy is a positive right. It's sort of just as you clinicians have noticed that pediatric gender medicine is exceptional in certain respects, if you're a bioethicist or a philosopher and you read some of these papers, it's sort of exceptional at the conceptual level too, because really, so truisms about the nature of autonomy, for example, are just rejected. So there's an interesting parallel between some of the radical approaches that you see in the clinic. You also see radical approaches at the level of theory, at the level of bioethics. Okay. Medically affirming pediatric gender medicine, I think, is at a crossroads. If the traditional rationale, the one that appeals to benefits of health, is to remain operative, then advocates must provide stronger evidence of a positive risk-benefit profile. If the rationale is these interventions improve health, then we need better evidence that that's true. On the other hand, if you want to adopt the gender embodiment goals approach, right, then you have to explain how the satisfaction of patients' current desires on their own justify invasive medical intervention. And I want to conclude by saying that it's very unlikely that respect for autonomy as a bioethics principle can do that work. Again, because respect for autonomy just protects people's negative rights, not their right to receive something that they want. That's all. Thank you.